Welcome everyone to our program, Breast Cancer 360, Triple Negative Breast Cancer Waiting for the Future. We are coming to you live from the Center for Social Innovation in New York City. We're so glad that you are here with us tonight in our audience. And for those of you at home, we hope you'll participate. All of you here and at home, that you'll ask questions, you'll be a part of the conversation. My name is Luann Kahn. I'm your moderator. I am a board member of Living Beyond Breast Cancer, and I am a 25-year survivor of breast cancer. I was diagnosed with an aggressive breast cancer at the age of 35. That was in 1991, the same year Living Beyond Breast Cancer was born, and we are celebrating our 25th anniversary this year. Again, as you can hear, we've got a live audience here, and of course, again, you at home, I want to tell you how you can ask questions, how you can participate. You can text your questions, and we understand questions have already started coming in. You can text us at the number 610-857-7186, and we would love for you to tweet as well, #TMBCDay. Before we get started, we have some thank yous. First of all, we want to thank our partners, the Triple Negative Breast Cancer Foundation, for collaborating with us on this fantastic program tonight, but also for collaborating with us on so many programs throughout the year to make sure that women with triple negative breast cancer get the best information possible. We'd also like to thank our sponsors, Celgene and Genentech. Without you, this program would not be possible, and we appreciate you and your contributions here tonight. It is no coincidence that we are having this program tonight on March 3rd. This is Triple Negative Breast Cancer Day. It is a day that we hope people around the world are paying more attention to this disease, which has not received as much attention as we would have liked, and as much research dollars as we would like to have seen. This is a day that we hope more people will learn about triple negative breast cancer. But for you at home, many of you in our audience, and certainly for many of our panelists, this is something that impacts your everyday. So let's meet our panelists right now as I join you. Dr. Tiffany Traina is an expert on triple negative breast cancer and a medical oncologist at Memorial Sloan Kettering here in New York City. Thank you for joining us. Roz Kleben is an oncology social worker also at Sloan Kettering and works with many triple negative breast cancer patients. Thank you for being here. Melissa Stolper, Kelly Anderson, Ricky Fairley, you all have had triple negative breast cancer, and thank you so much for being here and being willing to share your stories. I think it's important first that we start with some of your experiences. So let's start with you, Ricky, if you would. Tell us a little about what happened.
Sure. I will celebrate my 5-year cancerversary on October 20th, so I'm very excited that will happen this year. But I got triple negative. My doctor found it on an annual checkup, so make sure that you make that happen. And it was the size of a peanut, but it was stage 3A, triple negative. It was in 7 out of 10 of the lymph nodes that they took out. I had a double mastectomy, and then I did TAC chemo, I did radiation, and then I did chemo again. And I am happy, healthy, and terrific now, but I learned through the process that I had to get rid of all of the cancers in my life and figure out how to de-stress. So I divorced my husband of 30 years, ouch. I quit my business partners, and I moved to the beach.
You know, I have to ask you, I understand your oncologist didn't believe.
No, my oncologist told me that I had 2
triple
years to live. She had only had limited experience with triple negative. She was 38 at the time. And when I asked her, okay, what's your personal experience with what I had? And she said, oh, you've got 2 years. And I said, I have a daughter that's a sophomore in college, and I not only want to see graduation, but I need to work to pay for it. So me, you, and God have to work this out. And so God had another plan for me. And I believe that triple negative survivors are special because we don't have therapy to prevent recurrence. And I believe that God left me here to use my voice to talk about it, so that I do that every day.
We appreciate it. Thank you so much, Ricky. Melissa?
My name is Melissa Stolper, and I'm going to be a 3-year triple negative cancer survivor in 10 days on March 13th. Thank you. There's a lot of breast cancer in my family. My mother, who's with us tonight, has been always such a huge advocate of prevention and encouraged me to get tested for the BRCA gene. So when I was 32, I did get tested, and I knew that I had the gene. And rather than freak out and be upset and frustrated that I had the gene, I tried to focus on the fact that this is going to give me a roadmap. I call it my GPS. And I followed my doctor's instruction, and I had a prophylactic oophorectomy when I was 39. And I was always going for follow-up for MRIs, and I never missed an appointment. But unfortunately, we found a small lump 3 years ago on a regular mammogram, and I just had my clinical test just a couple of months prior. So the doctors knew right away that it was triple negative because it happened so quickly. And it was just a whirlwind for me, and as difficult of a journey as it has been, there have been so many incredible people like Ricky, like Kelly, like Tiffany that I've met along the way, and the silver lining here, or I should say how I made lemonade out of lemons, is I launched a blog called cancerfashionista.com, because I'm a fashion publicist, and as soon as I knew what my treatment was, my next step was to find out how am I going to look good in meetings, and that obviously helps you feel better. So I ended up putting a list together of products and services and experts that I loved, and my mom kept saying, I need that list, I know a friend of a friend, and finally I said, fine, and then I thought I might as well just put this on a blog, and that's how Cancer Fashionista started.
All right, that's great, and I know we'll hear more about that, and we'll continue to hear more about your experiences. Kelly, tell us a little about what
Hi,
happened.
my name is Kelly Anderson. I was diagnosed 12 years ago with triple negative breast cancer at the age of 36 years old. I was discovered on a baseline mammography. My doctor was sending her patients for mammograms at 35 years old. So she saved my life. So at 36 years old, I was diagnosed with a ductal invasive carcinoma, stage 2A. I did receive a double mastectomy because of the fact that they did find early cancer on the opposite side, on an MRI, by the way, not on a mammography. I went through chemo, I went through double mastectomy. I had a 3-year-old and a 6-year-old. Following my treatment, when I was declared cured, but during the course of my treatment, 3 months into my treatment, my sister was diagnosed with breast cancer. She was a year younger than me. So we started doing some research in the family, and we discovered the BRCA gene. My sister, ironically, was not a triple negative breast cancer, which leads to some interesting questions. We both were positive for the same BRCA mutation. However, I was triple negative, she was estrogen positive. I'm happy to say that Karen also is a 12-year survivor. She's my Irish twin. So both of us did go through breast cancer together. At the age of 39, I received a complete hysterectomy to remove my ovarian cancer risk. And I'm happy to report, I'm happy, I'm healthy, and I'm grateful I'm 12 years cancer-free.
Thank you. Thank you so much to all of you. And obviously each of you knows a lot about your individual breast cancer and your treatment. But I want to start with Dr. Tiffany Traina to first, let's define what triple negative breast cancer is.
Right, I think that's a great point. So right now when a breast cancer is diagnosed, there are 3 things that I often want to know as I start to think about the biology of that cancer. So besides size and lymph nodes, I want to know about 2 of the hormone receptors, the estrogen receptor and progesterone receptor. And I want to know the status of a protein called HER2, which is a growth factor that stimulates cancer cells to grow. So if all 3 of those markers are negative in the tumor, we call that triple negative breast cancer. The threshold and the cutoff for how that's defined has changed over the years. Even within the time since some of you guys have been diagnosed, The threshold for ER/PR being negative is actually 0%. That is now estrogen and progesterone receptor negative. And then HER2 has a complicated scoring system, but as long as the tumor is ER/PR 0, HER2 negative, that is triple negative breast cancer today. And that's actually a very simple definition.
But it means that you don't have those targets
Correct.
on your cell, your breast cancer cell, to treat. And so that puts you in this category.
Correct. Some of the most typical markers are lacking in triple negative breast cancer. But that definition is a rather superficial definition. That is really judged by what the surface of the cancer cell looks like. And I think what you'll hear tonight, and I hope that you walk away from this evening with, is the fact that it's what's going on inside the cancer cell that matters almost more so than what we're just seeing superficially on the surface. So triple negative breast cancer is not all the same thing. It just, for now, lacks estrogen, progesterone, and HER2 in its very simple definition.
And again, just what percentage of women with breast cancer will get triple negative breast cancer, and who is most at risk?
Great question. So the most typical kind of breast cancer is a hormonally driven cancer, and that's probably a good 3/4 or 80% of breast cancers. Triple negative accounts for about 20%, 15 to 20% of all breast cancers that happen. It tends to occur in younger women. There is an association between hereditary breast cancer and the genes BRCA1 and BRCA2 that you've already heard about a bit this evening. It, as I said, tends to occur in young women who are juggling families and careers, and on top of that now, a new diagnosis.
Okay, so look, we're hearing some pretty scary information. It is Triple Negative Breast Cancer Awareness Day. And, you know, on the morning news, there was a national report, and I know that some of you at home heard about it. You've already written in questions about it, hearing about the mortality rate and the recurrence rate. So that sounds pretty frightening. Is that the whole story?
No, I think that's a small part of the story. I think that, as you've heard to start with, screening is incredibly important. Identifying an early stage breast cancer is a curable situation. And so I first would just encourage you to be doing appropriate risk-driven screening to find early stage cancers. Early stage triple negative breast cancers are curable. So while it is true that there is a slightly higher risk of recurrence for triple negative breast cancer compared to a hormonally driven cancer, we do have many effective curative therapies for early stage triple negative breast cancer. And so while we are unable to get benefit from anti-estrogen therapy or anti-HER2 therapies, the backbone of curative therapy is chemotherapy. And I would highlight that for triple negative breast cancers, when women are beyond these first few years from a diagnosis, in many ways they're out of the woods. And there actually is a cure rate there. In contrast, actually, hormonally driven cancers can have very late recurrences, years later, 10 years later, 12 years later. And that's less likely in a triple negative breast cancer.
And is it true triple negative breast cancer responds, while fast growing and aggressive, it responds pretty well to the standard chemotherapy treatments we have right now?
Correct. That is absolutely true.
So let's talk about those treatments and where we're going, because I think everybody wants to know what's coming down the pike. But let's talk about what we have right now.
What do we have right now? So standard of care today to treat early stage and advanced triple negative breast cancer is chemotherapy. And we have some very, very good active drugs. A backbone regimen in early stage breast cancer involves anthracyclines and a group of medications called taxanes. And these are highly curative therapies. And what you've seen probably over the past 5 to 10 years are ways to tweak those drugs to get them to work better by adjusting schedule and by adding in more chemotherapy drugs. So some recent literature has shown the drug carboplatin in triple negative breast cancer and in BRCA mutation associated triple negative breast cancer has helped shrink cancers more before women go on to surgery. And there's some controversial data about whether there's an impact in helping women to live longer, but the addition there of yet another drug has helped improve outcomes for women with early stage triple negative breast cancer.
So the idea is to hit it as hard as you can in the beginning. With chemo, there may be other treatments depending on the kind
Right,
of
exactly.
cancer you have.
And we're just learning very recently from the San Antonio Breast Cancer meeting just in December that for women who received preoperative chemotherapy before having their definitive lumpectomy or mastectomy, that if the cancer failed to melt away at the time of their surgery, giving an additional 6 to 8 cycles or few months of an oral chemotherapy that's been around for years actually showed some improvement in survival. So we're finding more and more ways to use our current available therapies in perhaps better roles to improve survival.
All right, so let's talk about some of the exciting things coming.
Happy to. So what I mentioned before is this definition of triple negative breast cancer is a rather simple one, and it's really just a very superficial definition. What we've learned from looking at gene profiles within a cancer cell is that there are many different fingerprints to triple negative breast cancer. And they have different drivers sending signals to that cancer cell to grow. So ideally, what we would like to see in oncology is really personalizing treatment choices, seeing what is unique about a woman's particular cancer, what is driving it, and then pick appropriate therapies to target that driver. So within triple negative breast cancer, there may be upwards of 6 different molecular subtypes. Now, all of this, at this point in time, is really investigational. It's part of testing that can be done within clinical trials, but the idea would be to find what the fingerprint is of that particular triple negative breast cancer and choose novel targeted therapies to treat it. In advanced and metastatic triple negative breast cancer, I would encourage exploring these kinds of clinical trials. So we've discovered, and part of our research program at Sloan Kettering was recognizing that there is another hormone that can drive triple negative breast cancer. And it's not estrogen, it happens to be androgen, a hormone we think of more in men than in women. So we've had multiple clinical trials of novel anti-androgens that men use for prostate cancer that have helped to treat triple negative breast cancer driven by androgen, as one example.
So I know you're asking questions at home, and Kathy Amarad, you're getting some of these questions, and I know this morning on Good Morning America there was something mentioned about a new clinical trial. Did you get a question on this that you wanted?
Several questions on that, and they want to know, is there a blood test that
Right.
can predict a recurrence, which I think was confusing many people.
Sure. So I think while that's very exciting, I'm so pleased that this was on the news this morning to raise awareness about triple negative breast cancer, and also I think to raise awareness of the research that's going on to better understand the disease and to find appropriate therapies. So this idea of a blood test to predict an early recurrence for triple negative breast cancer is under investigation. This is not something that you can run to your local lab tomorrow and have a blood test and see the future. But it's a very interesting concept that if we were better able to identify who is at risk and then intervene with a therapy to minimize that risk, that would be fantastic. We're not quite there yet, although we essentially have chemotherapy that does that very same thing. The goal is finding a woman at risk of recurrence and using appropriate therapy to kill off the rogue cell, that microscopic cell that might be hiding out that at this point we can't find.
You know, I have to say, when I was diagnosed 25 years ago, when I asked the question, well, what happens if it comes back? There wasn't really much of an answer, but there is. I mean, if it comes back, and I obviously, and this is the biggest fear, and I know we're going to talk about this, what do you tell patients when they come back with a recurrence? What is there in the arsenal?
So definitely reason to be hopeful. There are so many drugs in the pipeline and in development outside of chemotherapy. I mean, we have a laundry list of effective agents from chemotherapy, but beyond that, as I've mentioned, an anti-androgen approach for androgen-driven triple-negative breast cancer. Another avenue altogether is this idea of recruiting the body's own immune system to fight cancer, to see it as something foreign that doesn't belong. So these therapies essentially take the brakes off our body's immune system and allow our own T cells to see the cancer as foreign and fight it. And so there are multiple trials going on right now of novel immunotherapy agents. either used by themselves or with chemotherapies, some really standard great chemotherapies that are available, to see if the combination may be better than just the chemotherapy by itself. So that's yet another approach. And can I add one more that's exciting?
Sure.
So
Oh yeah,
there's-
we want to hear everything that's exciting.
So this is also sort of hot off the presses from the San Antonio breast cancer meeting, of the idea of having a targeted, sort of a heat-seeking missile to the cancer cell attached to a little bit of chemotherapy. So they call that an antibody-drug conjugate. And there are several in development for triple-negative breast cancer, and one of which is targeting something that's in 80 to 90% of triple-negative breast cancers. So I think there's reason to be hopeful. There was a day when we didn't realize estrogen was so important in breast cancer, right? And we didn't have drugs like aromatase inhibitors and tamoxifen to target that. Well, that's sort of where we've been with triple-negative breast cancer, but we are identifying some of those targets now. And so not all triple-negative breast cancer is the same, and we're learning what the drivers are, and then we'll have a multitude of treatments that are already sort of on the horizon to treat based on biology.
Right. So, Kathy, yes, a question.
People are wondering what tests should be used to follow someone who does have early stage TNBC.
So, I think that this is a bit of the art of medicine. It's important to follow up with your oncologist. There really is no magical scan or blood test right now that will identify a recurrence. So communication is key. Listening to your body, knowing that, gosh, if something just isn't feeling right, something just isn't getting better after a couple of weeks, to give your oncologist a call. Now, everyone is still entitled to get a cold in the winter and back pain because you're lifting a grandchild. All of that's going to keep happening. So I think a rule of thumb is be out there, live life. If something's just not getting better after a few weeks, escalate that. Call for help.
But I think this is the scariest thing. And we're going to talk about this. The idea is after you finish that first round of whatever they hit you with, and we're about to talk about, and there's so many different things, then you wait, right? Then you're waiting and you're done, and you're listening to your body, and you're going in for checkups. But now, other people are getting some targeted therapies, and so that's where triple-negative breast cancer, women with triple-negative breast cancer are kind of like, maybe feel like you're in limbo. Maybe you want to add to that and tell us about how you chose your treatment. And I'm sure for each one of you and those in our audience, it can be different.
May I?
Sure.
I think, triple negative has been getting a bad rap, okay? I'm an occupational therapist. I treat post-mastectomy cancer patients. Why do I do that? Because I had cancer 12 years ago. I've become very vested in researching all of this about triple negative versus estrogen positive cancers. There are a larger population of my patients that are coming in with triple negative. So what does this mean? It's getting a bad rep. So what this means is, okay, triple negative, there is nothing else for us to take. And I'm speaking purely from a patient and also as a practitioner. I'm not a physician. So there's nothing else for us to take. There's no anti-estrogen medication. What does that mean for us? Okay, what that means is chemotherapy is there for us. I feel very comfortable with that. You're diagnosed with triple negative. This is an aggressive cancer. So these are choices you make in your treatment. For me to be the most aggressive I could, to do a double mastectomy, to completely eliminate my high risk of recurring breast cancer, because I am BRCA positive, that throws another element into that situation. However, but the triple negative itself, personally for me, I had a double mastectomy, I had a complete hysterectomy, and I am screened 4 times a year. Am I fearful? No, because I'm comfortable that I did everything I possibly could to remove this risk. What I see with my estrogen positive patients, however, is there is that little bit of struggle with some of these anti-estrogen drugs. In a way, I feel fortunate. I don't have to take Arimidex that causes severe joint pain. I don't have to take these drugs, which how much coverage is that drug really giving you? And if you read some of the literature, how much extra coverage are these estrogen positive patients getting that we're not getting by doing an aggressive therapy? So that's how I think about it from a medical standpoint, from a patient standpoint. I've done a lot of reading. Dr. Susan Love's breast book, it's a great book. I've done a lot of reading with that. If you feel comfortable in the way you treated yourself with chemotherapy and surgery, then I see no reason to feel confident that, you know, triple negative is not as much of a threat. That's how I feel about that.
Right. Roz, I feel like you want to, I sense you want to jump in here.
Yes, I do support groups for women who have early stage breast cancer as well as metastatic cancer. Today I had a support group in the afternoon, and an estrogen positive woman came in just about as disgruntled as you can imagine. She said, "This will never end, it will never end." She was just told she has a big choice. She is somebody who can't take tamoxifen because she has a blood clotting issue. So she could take an AI, an aromatase inhibitor, and either take Lupron, a monthly injection, or have a oophorectomy. And she said it'll never end, and she was just full of rage about the fact that she would have to take this drug for another 5 to 10 years. She thought that this would be over, and I was preparing to come here tonight thinking, we have this entire population of people who feel so much more endangered because they don't have the tamoxifen, and I sort of introduced that to her. She just couldn't connect with it. It was just going to cause her all of this pain and discomfort. I think that the triple negative, as you say, does get a terrible rap. You know, people were triple negative 20 years ago and didn't know it, and so they were saved the emotional trauma. The bad part was the doctors didn't know it, and so nobody was looking. Today, we know about it, so people are traumatized, but the doctors are working on a solution to this. And it won't be one solution, it'll be many solutions. But as you point out, you've had your therapy. The chemotherapy works in a very big way for triple negative, and when you're anxious, I think you need to think about these people and how long it's been and how far past they are. I look at the emotional dealing with cancer in two ways. There's cancer part A, which is chemo and radiation and surgery. When all you're doing is thinking about what's going on, is the wig on right? You know, do you have diarrhea or constipation? And then there's cancer part B, when the treatment is over and you have enough time, emotional energy, to think about the bigger issues. Will I make it? Will it recur? Will I be here for my daughter's graduation? Cancer part B is very difficult, and it's difficult for both parties. But what really works with cancer part B is time, just time. And so you are far from it. And as time goes on, you gain confidence. As Dr. Trainer said, with triple negative, when you're past 2-3 years, there's some amount of safety. Whereas with the estrogen positive folks, it could come back. I've had people where it came back after 30 years, which is really a shocker. They forgot they had breast cancer. But it's really with time that people will start to feel confident and better. And instead of tamoxifen or Femara, what people need to find is whatever avenue there is that makes you feel good. Is it diet? Is it exercise? Is it prayer?
So Roz, and we're going to really dig into the emotional impact and how to deal with it. But before we do, I want to talk to Melissa. Roz, how did you make your treatment decisions?
My treatment decision was pretty clear to me. I was fortunate enough to have caught my breast cancer very early. I was stage 1. The tumor was about 1.5 centimeters. And my oncologist said, you know, chemo might be overkill for you, but I think we should do it. And I didn't even flinch. And when they told me double mastectomy was strongly suggested, I just didn't want to die. So I had so much trust in my doctors, and I looked at them as a team. They were on my side, and although these are tough and scary decisions, and even when they said chemo, I was like, you mean where your hair falls out? Not that one, right? It's not gonna be that one. It was really hard for me to swallow, but once I knew that quite frankly, there weren't really many options. It was it was clear to me, and I just followed that path.
Right. And you felt confident with it?
Felt confident, and I pat myself on the back and my family and my physicians, because I'm with Kelly. I feel that given the situation and what the treatment options were, I could not have done better.
Ricky?
I agree. I was told that there was such a high opportunity for recurrence in my second breast, so I opted for a double mastectomy without a doubt. These are actually bigger than the ones that tried to kill me. I'm very proud of them. I wasn't really attached to my breasts, and I recommend that highly. But chemo, everything, I just was give it all to me. We need a solution. So I was, willing to do whatever it took to make myself well. And I think it's really important to explore your options, though. When I did get second opinions, just so I would have as much information as possible about it.
All right. Again, I want to remind you that you can text in your question. The number is 610-857-7186. And Kathy, you've got something for us.
Yes, people are wondering about environmental risks.
Environmental risks.
And other things they can do. What can they do to prevent? What can they take control of to prevent?
It's a great question. So for breast cancer risk in general, the two main risks are being a woman and increasing age. And we've yet to figure out a way to get away from either of those risks. You've heard already BRCA, right? I think knowledge and conversation. So know your family history, talk with your doctor. If there are guidelines, if someone has a diagnosis of triple negative breast cancer under the age of 60, guidelines are to get genetic testing to know, because of the prevalence of that BRCA gene in the setting of triple negative breast cancer. So number one, knowledge, right? Be aware of what your risk is. Beyond that, the literature about risk is a little squirrely. So there are things that you can control. Low-fat diet is helpful. Having a healthy body mass index, right? Good weight for your height, helpful. Alcohol in moderation. You don't need to abstain, but you don't want to go overboard. The numbers you're going to find in the press every day, you're hearing something else in the news, and that's because you don't have the gold standard of a randomized, controlled, blinded study. Therefore, you're going to get this sort of conflicting information from observational or retrospective looks. But really, those are some of the main things. Exercise, right? And these are sort of common sense. They're going to help with cardiac risk, and that's still a bigger killer of women than breast cancer or cancer in general. So those are some of the main modifiable lifestyle risks that you can control and do something about.
What's interesting to me, I mean, maybe we should talk about the BRCA gene and being triple negative, because that seems like a different, almost a different category. We've got two panelists, right? Two panelists who had
Can I ask a question in regard to that?
Yes, sure.
So my sister and I have the same BRCA mutation, yet I was triple negative and she was estrogen positive. So how is that possible in the same BRCA gene mutation that you can still have a very diverse breast cancer?
So it's very possible. So the presence of the gene mutation increases the risk of a breast cancer happening, period. But the most common kind of breast cancer to happen is a hormonally driven breast cancer. So while there tends to be more BRCA1 mutation carriers within triple negative breast cancer, it doesn't exclude the possibility of getting a hormonally driven breast cancer. It's just increasing risk in general, actually, by having the gene.
Now, with the triple negative patients, are there studies on what percentage of these patients are BRCA positive versus BRCA negative?
Yeah, so hereditary predisposition to breast cancer, not just BRCA1 or 2, but even some of the other way less common mutations, only accounts for about 8% of all breast cancer that happens. So while there's a higher likelihood of BRCA1 within women who have triple negative breast cancer, and I mean, it's still not the majority by any means, but it's more than that 8% that you would expect. While it's a higher number, it is not universal. So while I think many folks who are young, even with a family history, will go for testing and find that they're negative, I think one thing to keep in mind is there's a lot we don't know yet. So continue to have these conversations with your doctor, because we're finding new genes all the time. A third gene called PALB2 was identified within the past couple of years, and that also predisposes to breast cancer. So this is a moving target.
Ricky, there was a drug you wanted to ask about.
Yes, the drug that that Jimmy Carter used. Actually, I have a friend who's 28. She just became metastatic. It's now in her liver, and that's one of the things I wanted to bring up, because I do think triple negative is more prevalent with African American women. I've heard as much as 3 times the rate, and younger Black women. And my friend Amber, and so she actually is in line. She's trying to get into the trial of the drug that Jimmy Carter took. That I can't pronounce, Doctor.
That's okay.
Yes.
So that particular agent falls into this class that I alluded to of immunotherapy. So there's a very tight relationship between our immune system and, say, a cancer cell. And as soon as our immune system sees a cancer cell, at the same time it starts fighting it, it also puts the brakes on, because an uncontrolled immune system can cause illnesses that you may have heard of in friends or family, autoimmune conditions that can damage the liver or the intestines or skin, or thyroid. So an uncontrolled immune system is a dangerous thing. So it's a very tight system that while the immune system's turned on against the cancer, it's turned off at the same time. So this drug that you're referring to is one of those compounds that takes the brakes off, lets the immune system fight the cancer cell without really turning it off at the same time. And that has shown great promise in melanoma in particular. And there are multiple studies going on in breast cancer, several phase 1 trials that have been done in triple negative breast cancer, and just at our San Antonio meeting in December, looking at this really across breast cancer, as well as hormonally driven tumors.
So how does one decide whether they should participate in a clinical trial? Who's a good candidate? And if you decide you want to look into it, how do you do that?
Okay, so a couple of resources. Again, I say, number one, talk to your doctor about it. If your doctor is not aware of available clinical trials, there are resources. Clinicaltrials.gov has a search engine to limit by disease type and geography, so you can look within a certain mile radius. I would encourage you to look at the Triple Negative Breast Cancer Foundation website or the Living Beyond Breast Cancer website to find and have additional resources to identify clinical trials. There are different kinds of trials, some that are taking a very new drug to first time they were used in a person. And that can sometimes be a bit scary, right? We recognize that we don't know as much about those drugs, but there can be a fantastic rationale for why that might work in your tumor.
So who should avail themselves of that?
I think for triple negative breast cancer, it is reasonable for anybody to have this conversation about clinical trials, because the standard treatments are not going anywhere. They remain available.
But to take a drug that we don't know a lot about, who is a good candidate for that? I mean, is that someone who has metastatic breast cancer, or,
Or someone who's 28.
Right.
With metastatic.
Well, so
Metastatic.
exactly. So I think in metastatic breast cancer that has grown, as we've talked about, beyond the standard therapy options, it is very reasonable to explore new drugs that have an exciting rationale for work. And the drug that you're referring to is already far along in development. They know the dose to use. It's shown some activity already. So that builds confidence in participating in a trial like that. I think what is a challenge is how to compare one study to another if you're presented with multiple options. And there, you need to have some guidance from your doctor, but many times either trial would be a reasonable alternative. We don't have a crystal ball. Your docs don't know the future. So when either trial is reasonable, trust your heart. It could be as simple as logistically, which is going to fit into my lifestyle better. If one drug is going to have me spend, or one trial is going to have me spend my time in the hospital constantly, whereas another may only be a weekly treatment or once every 3 weeks. Well, it's okay to make choices like that in one study over another if your doctor really can't help prioritize for you.
Right. Kathy?
We have a number of questions on immunotherapy and how people can find out information about the trials, and are the trials covered by insurance?
In general, for clinical trials, things that are standard of care, seeing your doctor, having blood work done, having your scan done, those sorts of things generally are not covered because folks are hopefully covered already by their insurance provider. Anything that is purely for research purposes or investigational, if it's a brand new drug that is not FDA approved, that is provided by the manufacturer, the sponsor of the study potentially, or the pharmaceutical company who makes that new drug. So that is provided as part of the study. And any research, purely research related procedures like biopsies or special blood work, that's often covered by the trial. That will all be spelled out in a document called an informed consent. And again, this is all about having a dialogue and conversation with your doctor.
We also have some follow-up questions about African American women and why are more young African American women dying in greater numbers than white women.
I'm not sure we fully understand the biology of that. We've seen that as an observation. We also see that triple-negative breast cancer is higher in prevalence in Hispanic women, but I don't think that we fully understand why that is.
Right.
Okay.
Anything else? While we're here, you know, I was talking to the executive director of Triple Negative Breast Cancer Foundation, Haley Dinnerman, who, you know, I must say it still surprises me to hear that after we do know so much more than when I was diagnosed, that there are still women, young women, who are coming to their doctors presenting with a lump and being dismissed. And
Amber was dismissed.
Yeah.
and then finding out that it is an aggressive breast cancer. I mean, that happened to me. I walked around with it for 6 months. That was in 1991. But to hear this is continuing to happen surprises me. What are we telling? I guess Haley was saying if there's just one thing that she would like everyone to get out of this is to trust your body and not to let someone dismiss you. But I mean, how is that happening today?
Sure. You know, I think that folks are still not expecting to find breast cancer in young women, in a woman in her 20s. More often than not, it isn't breast cancer, thankfully, right? But you do need to trust your body, listen to your body. If something is not improving, if it's getting worse, even in the face of negative imaging, right? You had a mammogram and it was negative, but you still feel this lump there and that just doesn't belong, then that gets escalated to see a breast surgeon. Right? If you're not comfortable with it and if you feel like your concerns are not being addressed, then escalate that, don't sit on it.
I think if we could accomplish anything, it's organizations such as LBBC and the Triple Negative Foundation, is to get the word out that if you're a young woman and there's something odd that you don't like, and the first doctor says it's nothing, and the second doctor says, you just keep going. Because when I have a young women's metastatic support group, and the bulk of those women were diagnosed at stage 4. Because some physician told them a year before or 2 years before, oh no, at your age, you're 32, this couldn't be. So if we could just get that word out to the population that they really have to pursue that.
All right. Well, maybe we should go over that again. What are the symptoms? What are the things that we should all be looking for?
So I think, number one, you want to be screening and try to catch something before you're feeling it. Right? But triple-negative breast cancers can show up in between doing your appropriately scheduled scans.
Very quickly,
So-
almost overnight sometimes.
Right, exactly.
My
So-
doctor told me that if I had come in a month earlier or a month later, it would have been a different story.
Yeah, so not sitting on things for too long, feeling a lump, noticing a change in the appearance of your breast, the shape of your breast, the color of the skin, redness, dimpling, a change in the direction of the nipple, right? If all of a sudden it starts to invert or turn inward. If you were born that way, that's your normal. But if it changes, that's a reason to see your gynecologist, see your internist, talk about it with your doctor.
What is the role of radiation in treatment for triple negative?
So in early stage breast cancer, doing radiation following a lumpectomy or breast conservation has the same survival rates as having done a mastectomy. So you've heard a lot about bilateral mastectomies or double mastectomies, and I think it's important to keep in mind that with a diagnosis of breast cancer, radiation and lumpectomy hand in hand have the same survival as mastectomy. which is telling you that it's not what's going on in the breast that is ultimately causing trouble. Right? It's breast cancer recurring somewhere else in the body. And that's where chemotherapy and other targeted therapies are going to be helpful. So doing a mastectomy on the opposite breast is a prevention strategy for new breast cancers down the road. And that's a conversation you need to have with your surgeon. You need to know your personal predisposition to a new second breast cancer happening. But radiation certainly has a role for preventing a recurrence within the preserved breast. It allows women to keep their breast and not need a mastectomy.
Okay.
I have a question. So as a mother of 2 daughters, 23 and 30, my instinct is go have babies, nurse your babies, and then we're cutting the boobs off and getting all new ones for everybody. Because so much is unknown about triple negative, especially within Black women. And so my instinct is, let's alleviate the problem altogether. What do you think about that?
So I think it's hard to advocate for that in the absence of a known genetic predisposition, where some women could be living with a 60 to 80% lifetime chance of developing a new breast cancer. Certainly having a first-degree relative, right, mom with breast cancer, means you need to be talking about this with your gynecologist and potentially starting your screening earlier. You mentioned 35, right? Or someone mentioned 35 as their sort of baseline mammo, and then starting annually at 40. There's a lot of controversy about when to start mammograms and how often to start mammograms. I have to say I clearly have a bias because all I do is take care of women with breast cancer. And there is data that in women between 40 and 50, you do improve survival with screening. So it's a public health decision about when to start. But for the individual before me, I want to be sure we're starting at 40. And for folks from a family of high risk, even sooner than that. But I don't know that you necessarily need to rush to doing risk-reducing mastectomies in the absence of a very high risk. There are screening modalities like MRI added to mammography.
But that's a really, you're saying, that's a tough decision when you're told you have triple negative breast cancer, because you may feel like, well, I don't know where I'm going to fall in this, and that's an emotional decision too. So how do you decide in your treatment, should I do more? Should I have surgery, even if it's not absolutely recommended, even if you're doing chemotherapy and radiation, but you emotionally feel like you want more insurance, I guess. But what you just said is that doesn't necessarily give you more insurance?
Right. So I think it's a distinction between, yes, you don't want fear to be driving a decision in that moment, and that's why you really need to have comfort with and trust in your doctors and have these conversations and get extra opinions, because operating on the opposite breast is not going to improve survival and prevent recurrence of the triple negative breast cancer someone was just diagnosed with. That's going to be driven by chemotherapy and treatments that go everywhere in the body, right, to kill off the small cell that might be hiding out somewhere. So here is another example where time is on your side, that if you're too confused at the moment to make a decision about the opposite healthy breast, then take time to decide. What you need to do is do the cancer-directed treatment for the breast that has had cancer and gather information and make sure you're making a decision that you have no regrets about.
And again, we want to
often the decision about prophylactic mastectomies is an emotional one. And I think most doctors are opposed to it from a scientific medical point of view. And the folks that I see who do that are doing it from a emotional point of view. They will sleep better if they do that. I had a young girl whose mother had the BRCA gene, was estrogen positive and died of metastatic breast cancer, and she said after her children are born, she is going to have bilateral mastectomies and an oophorectomy, and she did not want the BRCA test. She didn't want anybody in a position to talk her out of this. This was a firm decision that she made. Her father was not in the picture, and she and her brother took care of mom, and she felt the only way she could rest was to make sure that she herself was safe. Now, the doctors may have told her that won't create safety. it's what she needed to do.
Do you relate to that, Melissa? Yeah.
Very much so. In fact, the day that I sat down with my oncologist was the same day that Angelina Jolie announced her prophylactic mastectomy. And I have to be honest with you, I love my doctor, but I came into his office so angry. I said, why didn't you tell me that I should have had a bilateral prophylactic mastectomy? And he said to me that even knowing where I sat right there at that moment, having stage 1, he wouldn't have recommended it because it is life-altering. And I think the overarching theme here is just to know what your options are, and everybody is different, and everyone needs to make their own decision as far as prevention.
Right. But you know, this is the element that wasn't there 25 years ago, the internet, and all what everybody else is doing and what all the celebrities were doing. Quite frankly, they weren't talking about it in 1991. And that has an impact, just as it did on you that day. But she's having it, and she's got access to everything. Why shouldn't I?
Exactly.
It's very confusing.
I think one of the things that breast cancer has made me fearless. Fearless. I really am. My only fear is my daughters. That's my one fear.
I think we all fear for our daughters.
Because we don't know enough. And so, you know, it is emotional. And I think, you know, the science could say whatever, but to me, there isn't enough science to convince me that my emotional state is not important or shouldn't be recognized, right? So if you could give me data, great, but I don't have the data for the next generation. And so, you know, that's why I believe that my daughter should get mastectomies.
Well, I want to talk about how we should be good information gatherers. How do we get correct information? Before we do, I think Kathy has some questions.
I do. There's a number of comments about making the mastectomy versus radiation decision and how painful and difficult it is. So it's echoing everything what people are saying here. In other treatment decisions, someone's asking, what about women who have substantial residual cancer after neoadjuvant chemo? Should they get more chemo?
Excellent question. So we finally have some data to guide us here. Granted, it's one study, but just reported at San Antonio. There was a study conducted in Asia, mostly Japan and Korea, looking at women, not just triple-negative breast cancer, but hormone-driven breast cancer, who had received neoadjuvant therapy and failed to have what's called a complete response, where everything melted away. There was some residual disease there, and it was removed at the time of surgery, but that leaves a lingering higher risk that the breast cancer may come back again. So in this trial, women were randomized, flip of a coin, to receive an oral chemotherapy versus standard of care, right? Move on to radiation, hormonal therapy if appropriate. And they found that there was improved breast cancer-related survival and overall survival. And that's the first trial that has shown us that more chemo in that situation is necessarily a bit better. So it's one piece of data out there, yet it's an FDA-available chemotherapy here in the US. So I think if you're in that situation, talk to your doctors about this new data. Obviously, we'd love to see that this is replicated and consistent. But yes, there may be a role for more. And that's an opportunity for clinical trials also. Not just chemotherapy, but look and see what else is out there. Is that an opportunity to harness the immune system or find a targeted therapy that might work?
Should we talk about, I mean, when you have triple-negative breast cancer, you're at high risk, or you have the BRCA gene, should you be looking for a certain facility, kind of hospital, kind of place to be treated? I know that's kind of a
loaded question.
I know, but still, we're talking to people all over the country with different resources.
Sloan Kettering, of course.
I mean,
So, you know, I think you've heard some examples of providers maybe not being so familiar with triple-negative breast cancer. So if you get that sense, then you should seek alternative opinions. I obviously think that there's tremendous value to academic institutions, and so if there is one close by, you know, to seek out an opinion and have, you know, I think that as an oncologist, I love to work with my colleagues in the community and in other academic centers and in industry because we're all there with a shared mission. And so if there's something I don't know, I'm not shy about asking somebody for help. If you're getting a sense that your doctor is not willing to ask for help when they don't know something, you need to seek alternative help.
That's so hard to know. I mean, how important is it about getting a second opinion? I mean, should that be a standard thing or just accept whatever it is that you're first told? I don't know. Do you all have a
I
feeling?
think you should get a second opinion, and well, maybe my doctor didn't know a lot, so that led me to do that. But I think anyone should do that because you want to have information. You want to be able to know that you've done everything you can do, and kind of looked at all the opportunities and resources you could find. So I don't think it's bad to do that at all. I think you should fight for yourself.
And I mean, I guess the other, and again, I know this is a loaded question, but is it better to be at a facility that is doing clinical trials or has more cutting edge drugs, possibly?
I think that there are excellent standard of care therapies out there. And as you said, there are folks around the country with varying resources. And admittedly, these treatments are challenging. So remember, these are young women also juggling their career, their kids at home. I don't want somebody to have guilt that they elected to do a standard therapy close to home because it's convenient. That's okay. That's curative therapy.
Right.
But it's nice to have potentially somebody else in your corner to run things by. And so it comes back to how do you know what you don't know?
Right.
You need to know what are valuable data-driven resources out there. And so some of the websites we've mentioned, the American Cancer Society, again, clinicaltrials.gov, there are great resources out there. And if things are suddenly not connecting, then you need to seek help.
Kathy's got a question.
Yeah, before we close on this sort of medical treatment, we've talked a lot about young women, but older women get TNBC as well. And what advice do you have for them?
I think simply chronologic age doesn't really matter. It's somebody's functional age, right? We were just talking about some of our patients. I'm not pointing at you, but we were just talking about.
Yes, of course.
Right, I have patients in their 80s that act like they're in their 40s, and so it's not their number of age, but their overall fitness that helps in determining therapy, and always balancing the risks of what we're going to do with the potential benefit and trying to do no harm at the root of all of this. So not chronologic age as much, but functional age.
But that's confusing because I think of triple negative breast cancer as being that fast growing breast cancer that attacks younger women, and yet, because it used to be thought older women get slower growing breast cancers, but not always.
No, I think it comes back to the variability within the biology. Not all triple negative breast cancer is the same. That subtype that I mentioned that's driven by androgen seems to be happening in older women. Right now they're still younger in general, but they're older than what you typically think of women with triple negative breast cancer. So I think it's the biology. It's not someone's age. It's not just the fact that it's triple negative.
I was on the old end. I was 55. I'll be 60 this year, so I was on the sort of the old end of it.
Yeah, it's not old.
It's not old, but
No, that's a wonderful example of functional age. You're like 32.
Good 30.
I have an off-topic question. Radiation came up, radiation treatment. Do you find I'm seeing in some of my patients that come into my office that they seem to be radiating more patients nowadays than they did 12 years ago. Now with radiation comes that risk of lymphedema. Do you have any comments in regards to that?
So I think where we have data is radiation is appropriate with breast conservation, especially if we're talking about triple negative breast cancer. So if we're seeing more breast conservation, we'll see more radiation that goes hand in hand with that. The other bit of data that is, I think, more widely embraced is that the presence of a positive lymph node, even in the setting of mastectomy, can improve outcomes with post-mastectomy radiation. So you may be seeing women who perhaps in the past who had a mastectomy and not get radiation unless they had a very large tumor or many positive nodes are now being referred to have this discussion with their radiation oncologist even if just one lymph node is positive. So that might be what you're
Yes,
seeing.
and I am seeing it also even in the double mastectomy patients. And you had mentioned it's more common to have lumpectomy, radiation tag team together. Even with the double mastectomy chemo patients, I'm also finding the consensus is a lot of these women that are coming in are getting chemotherapy, radiation, and double mastectomies.
But again,
So-
the radiation there is driven by either the size of the tumor that was there or an involvement of the lymph node in the setting of the mastectomy. Right? And that is to prevent a recurrence right there within the chest wall area. So you think about radiation as just the beam of a flashlight. It's only working where you point the beam. So I kind of think of it as an extension of surgery, or say a sort of breast chest wall directed treatment, as opposed to more systemic treatments like chemotherapy that go everywhere.
So I'd like to change this up. Oh, Kathy,
Just
before I change the subject.
You know, people are very concerned about the long-term impact of chemotherapy on their bodies and are wondering how you make choices about 4 treatments, 6 treatments, et cetera, and how you weigh those risks.
That's, again, the art of medicine, and we have some data that guides us. So chemotherapy sounds scary, right? And you sit through a consultation that's an hour and a half, and you hear the laundry list of all the bad things that might happen. And I think it's important to frame that with, well, what's the list of side effects that can happen if breast cancer recurs? And obviously nobody comes in super enthused to get chemotherapy, but it's a balance of risk and benefit. And so some of the side effects that sound really scary, leukemia that might happen years later, putting it in perspective, that's way less than a 1% likelihood. But the absolute benefit of doing chemotherapy way outweighs that. One of the risks, a short-term risk, but hair loss. I mean, that's been devastating, and you hear that again and again. Well, just this year we have the FDA approving cold caps to mitigate hair loss with chemotherapy. So, I mean, that's a meaningful quality of life improvement, helping you to get the effective drugs even if they're going to cause hair loss. The heart damage scare really, I think, is small risk, single digits, but these are very personalized choices that you have to talk with your doc about.
So again, we encourage you to continue. We love that we're getting these questions, and you can text them in at 610-857-7186. I want to talk about the way, we're information seekers, and there's so much information out there. And when you're diagnosed with triple-negative breast cancer, that can be a good thing and it can be a bad thing. How do we gather accurate, good information that is useful and doesn't scare the hell out of us? What do you think? Roz,
Well,
will
I
you
think
tackle
you have-
that one?
I'm basically opposed to, as I said earlier, Dr. Google, because I think that is a very upsetting factor for most patients. They go on, they read it generally at 2 o'clock in the morning, so that you can't contact anybody reasonable, and it's terrifying. I think you shouldn't do anything until you get to your doctor and then ask what they would recommend as reputable sites. The other thing is you need to know everything there is to know about you, not about the world of breast cancer. So that I think to keep yourself at a lower level of fear is the best thing. And there are wonderful reputable sites, and you would get that from your physician. I know at Sloan Kettering, and I'm sure in this day and age, every place, we put a high premium on keeping patients educated. But just about you, what you need to know, not all the other stuff that you have to ask yourself, how does that help me?
Do you have experience with this? I'm sure we all go looking.
Dr. Google was pretty amazing when I was sick.
Right.
But it's not only what you look for yourself, but everybody in your life. Oh, you know, I Googled XYZ and I saw you're going to die.
Right.
So, I mean, it's all out there. My kids, and literally my daughter would be on the phone with me if she wasn't at the doctor appointment with me. And by the time I got in the car, she had Googled every word the doctor said and more. So she had like a report of like, you know, pages of, okay, this is what we have to look for. So I think the internet's crazy, but I think one of the things that we try to do at the Triple Negative Breast Cancer Foundation is put the information that's valuable together. And I think we've worked really, really hard. Haley has worked really hard to make that happen so that the information you get is real. And the best part of it is we have these discussion groups, and you can go on at 2 o'clock in the morning, and women are talking to each other about anything, you know, my underwear is red, whatever, but they're talking about, you know, what do I do? So, and I think those conversations are very candid and very real, and it's an incredible value to women who are struggling.
That support is so
From each other. And
so
I
important.
think what I find too is that you know, I don't want to talk about other breast cancer. It's irrelevant to me. I want to talk about triple negative. I want to talk to women who've had triple negative, who have had what I had.
Right.
Because I think we're special, we're different, and we don't have the answers that other people have. So it's really important to be able to find that home, whether it's on the internet, in a support group, or wherever. But I want to talk to women who had what I had.
Right. And I'm sure there'll be a discussion tonight about, you know, the Angelina Jolie's surgeon talking about new clinical trial for triple negative breast cancer. What does that mean? And,
Right.
you know, but some of the words she used were pretty scary today. So I don't know. Do you,
There
go
are
ahead.
really two issues. One is from a medical point of view, which is why you would talk to Dr. Traina. How would you handle triple negative as opposed to HER2 positive or ER positive? But when it comes to the emotional effect of having a diagnosis of breast cancer, I've seen it as the same. So that the woman who is estrogen positive is terrified. And Dr. Trainer and I shared a patient a very, very young woman who had about, 10, 12 positive lymph nodes, estrogen positive, and she kept saying that I'm different than everybody else, and she felt different because she was young and because she had so many positive lymph nodes. She kept, remember, Jennifer? She kept saying, you have to do something else. Well, you've got tamoxifen. She felt so endangered. So I think emotionally, it's really the same thing, certainly not medically, but that feeling that you're vulnerable, that you're frightened, that it's something, so that while she was ER positive, she saw herself as independently at terrible risk.
But
Which,
I
in fact, she was.
But I really understand why triple negative breast cancer, women who are coping with that want to talk to each other. I mean, I do. It makes sense to me. Melissa, do you relate to that?
Absolutely. I mean, I know even when I first heard triple negative, I'm like, that sounds triple bad. I mean, even the name is just like, oh. And then when you tell your friend, well, what kind of breast cancer you have? It's triple negative, and they don't know, and then they are doctor Googling it, and that's like the worst thing. So I think, you know, as far as, you know, to your original question about balancing the gathering of information, I think definitely stay off Google. Listen to your doctor. If you have a question, ask your doctor. And specific to triple negative breast cancer, I think the Triple Negative Breast Cancer Foundation.org is fabulous because yes, at 2 in the morning when you can't sleep and you want to talk to someone who's the same stage as you, maybe even the same age, it's amazing how their message boards are actually all divided by metastatic, everything. And you know, just you could really scare the life out of yourself, and your family can do the same. So I just think, just make sure you're getting your information from good sources.
All right. Kelly, any thoughts?
I'd say the biggest thing that I've learned through the years is stay away from negative people. Mm-hmm. I was in chemotherapy, and a woman came in, and they hooked her up on an IV next to me, and it was only my second chemo, and I was really frightened. And this woman sits down, and she says, honey, I had a reoccurrence after 11 years. It always comes back. And I was like, oh.
She probably wasn't triple negative.
And I just sat there, and the nurse says,
That's right.
I said, you know what, next time I come in for chemo, don't put me next to her. And the nurse said something to me, and you know, this really put my mind at ease as far as the fear factor, as what we were talking about is, and what Dr. Traina was talking about, every breast cancer case is different. Mm-hmm. Every triple negative breast cancer case is still different. Every case is unique. Just because something happened to somebody else doesn't mean it's going to happen to you. Stay away from negative people. That's the biggest thing I learned. Stay positive and do your research and talk to your doctors.
That's why my hashtag is triple positive.
Triple positive.
I love that. Triple positive.
There you go.
Right, yeah. then let's talk about how do you stay positive? Especially when you're in that, okay, maybe you've finished that first year, you've gotten through the treatment, and now you're out there without any treatment. Now you're living again, you know, but you're aware and you're watching. How do we feel like we get to take control of our lives again?
Well, I quit my life and started a new one. I had to get rid of all of the cancers, and I really made some pretty huge life changes. And I had people saying, "You're crazy. You know, what are you doing? You have chemo brain. Why are you doing these crazy things all at one time?" But I really felt like I had to change a lot of things in my life and find peace. And so I did, and I have it. But I mean, I think every day you have to find your happy place. I have a dance party every day, whether it's in my car, on the beach where I live, or somewhere, but if it's for 5 minutes, 20 minutes. But I think you have to find a happy place where you can take yourself and find peace.
How much is the fear of the cancer part of your daily life now?
I'm fearless. And I feel like I'm blessed to be here and that I should live every day to the fullest. And if I can help someone every day with my story, I try to do that. I try to talk about it as much as possible so I can help somebody else deal with it.
So that the terrible fear at the beginning has lessened.
Yes, time has definitely helped.
Time and the things that you've done to your life.
Yeah, I think so also. But I mean,
time is
a great healer, I think. But every morning you wake up and you look in the mirror and you see your scars that are lessened, but still they're there. And you think about it. You look at pictures and you see things, and people remind you of it. So it doesn't go away, but it does. The fear does minimize, and you think, "Gosh, I made it another day. I made it another hour. I made it another year." And I'm okay. I don't know what you can do that. I mean, I give it to God. I feel very blessed, and I stand on my faith every day to, make it through.
But definitely fear of recurrence seems the number one psychological issue that triple negative breast cancer survivors, of course, true. But how do you deal with that?
I would say I couldn't agree more that time does heal. It really does. That loud noise of recurrence, that voice gets softer and softer. Mm-hmm. I think the two toughest chapters of being a breast cancer survivor for me, was the actual diagnosis and my last day of chemo. You imagine your last day of chemo, you're throwing parties and you're going out with your friends and you're like, yeah, I did it. But you're under the care and the watch of all these doctors and nurses, and it becomes like a womb. And then when they tell you, all right, off you go, we'll see you in a couple of months, that was very scary. And it took me a long time to really embrace my life again. Mm-hmm. And I think my family, my friends, and my career, just throwing myself back into my normal again, has helped a lot.
Right.
That's cancer part B.
Cancer part B.
Can I add
Love
on that too? My oncologist just told me that I'll have a PET scan April 1st, and then I don't have to have one for a year. And that is very scary to me, after going every 3 months, and then every 6 months. But the thought
because you felt like you had that insurance,
Yes.
someone was looking.
Yes, but to say, oh no, a year's gonna go by, that's very scary. So it's making the fear come back a little bit, so.
Right. Kelly?
It's interesting what Melissa just said, and I've had people tell me this, I experienced it, your last day of chemo, everybody's cheering, it's over, it's over. No, it wasn't over. The psychological aspect does hang around after chemotherapy. Your friends and family are happy you're finished with chemo. You're weak. You can't do the things you used to be able to do. You have scars, you had surgery, your hair's still gone. Yeah, so physically, psychologically, and one thing I do share with friends and with patients is it's going to take you time to recover from the trauma that you just experienced. And yeah, it's a trauma, you have to allow yourself time to heal from that, but time does help. Getting back to a normal routine is what helped me. Going back to work, getting back with my friends, and time is really what helped.
And if I might just add, I met Kelly because I needed post-mastectomy rehabilitation. I had a hard time with the range of motion. And the last thing you want to hear as a chemo patient is that you have another doctor to see or another practitioner to see. But I call her my breast cancer big sister because I would start to look forward to my appointments because she knew exactly, if I said, oh, I'm on Taxol number 3, she'd be like, oh, you're gonna feel like hell tomorrow, but in a few days, you're gonna feel awesome. You're gonna be cleaning the house like 24/7. And she was right. And so she really, I felt, it's like when someone clears a path for you, that's how I feel about Kelly. I was able to walk, to continue.
Well, that was my therapy. I opened up a breast cancer rehabilitation practice. When I was on my chemotherapy and I had double mastectomy, I'm an occupational therapist. Nobody sent me for therapy after all my surgeries. I could not move my arms. So I vowed when I was done with treatment, somehow I was going to get a little therapy practice together and I was going to work with post-mastectomy patients. And to this day, I do that. I do breast rehabilitation, I do lymphedema treatment, and Melissa was one of my patients.
Lucky.
No, it's wonderful. Roz, of course, time definitely helps. But in the meantime, and you're counseling triple negative breast cancer survivors all the time, what do you tell them how to get by the day-to-day?
Well, the first thing to do is to be honest with how you feel, because most people, as the two of you have talked about, feel rotten. And you don't have to comply with the family who says, it's all over, why aren't you happy? Well, it's over for them, it's not over for the patient, so you can't just jump over it. You have to go through it and talk about and deal with the things that you're afraid of. At the same time, let life come in. And what happens after a while is that life takes over. You go back, you're finally taking care of the family, you're cooking dinner, or you're shopping, or you're going back to work. And so your mind is filled with life. And as time goes by, you're occupied with other things. I remember a patient once said to me, oh, a long time goes by when I don't think about the breast cancer. She was about 6 months out. And I said, how long? And she said, an hour. So it just shows the hold it has on you. I tell people that it takes a year to a year and a half from the last treatment, whether that treatment be radiation or chemotherapy or the exchange, because you can't start recovering while you're still in it. And it's truly, well, it's like mourning because you have so many losses. It takes about a year to a year and a half. And then as far as gaining confidence, everybody finds something else. It could be religion, it could be diet, it could be exercise, so that while the doctors do not have a list of things that is science-based to help you be well, patients pick up things that for them are science-based, like no sugar. You hear that all the time. Now, I know that that is not, am I right, science-based? Okay, but you get a patient who feels that way and she turns around the way she eats, and that feels good because it gives you back control. Does that last a lifetime? No. It gets you through that first year and year and a half. But whatever helps, whatever works, being with other women who have been through it, because nobody understands what it's like except other people. Your community thinks there's something wrong with you, that you're not excited, that you're not celebrating. So just to be validated by other people is what helps.
Kathy, we have a question.
Yeah, both Living Beyond Breast Cancer and the Triple Negative Breast Cancer Foundation have programs for metastatic people who do recur. And I'm wondering, Dr. Traina and Roz Kleban, if what you would say about the medical treatments and also finding hope and as you begin your journey as a metastatic patient.
So I think there are many, many treatments. So if you step away with any message, is that metastatic breast cancer is treatable. Metastatic triple negative breast cancer is treatable. There are many available standard therapies. And I think never before have I seen so many trials dedicated to triple negative breast cancer, where there's recognition that it's different, recognition that it's not all the same thing, and a really joint effort between academic centers, industry, focusing on developing new drugs to treat triple negative breast cancer, even metastatic triple negative breast cancer. So have hope and utilize those resources around you to find those new therapies and ask the questions. And if you're not sure what to ask, check out the resources of TNBC and Living Beyond Breast Cancer, because that will be a footprint for you of what to ask.
Roz?
Well, metastatic disease is a whole other kind of ball game, and truly with metastatic disease, it's almost imperative that you stay off the internet, because there is just the most ghastly statistics there that is not good for anybody to look at. And I have talked often about the fact that metastasis is the new C word. And it's just recently that we talk about metastasis. I've been doing this a very long time, and for years and years and years, they never talked about metastasis. We have 2 metastatic groups at Sloan Kettering, and for many years, up until about a year ago, it was the only metastatic groups in the city. Now that is just ridiculous. So working with that population is to work very hard on getting people to live for the moment and to see what's good in their life and to really grab hold of that. But it's really a constant struggle. And at that point, I think, would you say that the both communities kind of come together? Because a lot of the metastatic patients have, the hormones are no longer working.
Sure. I mean, I think at some point, even for hormonally driven metastatic breast cancer, it no longer responds to anti-estrogens. And so there may be sort of a joint, as you said, the community comes together. There are many shared opportunities, but the biology is different. I think it's really important to recognize that living with metastatic triple-negative breast cancer becomes a chronic condition, much like heart disease or diabetes, that doctors aren't so great at making go away, but can be managed. And so you want to, if you find yourself in that position, to be living with your cancer, but to not stop living, right? Because
Right.
this is a treatable cancer.
What we try to engender in people is that this is a chronic illness. You need to leave the cancer with the doctor who's going to take care of it, and then you go about your life and do everything that you ever did and what you're interested in, some new things, changing life, as you suggest. It's easier to say that than to do it.
Well, and I think in terms of all the treatment options that are out there for metastatic triple-negative breast cancer, it is important to make choices every time you're faced with options for therapy to think about quality of life and quantity. It's all important because this becomes a marathon and the effects of one therapy can linger. So you want to be choosing therapies that obviously are effective, but also can improve quality of life, minimize symptoms, and help you to continue living life.
Kathy, any other questions?
Oh, there's lots of them.
Wanna give us
I'm wondering if we want to open it up to the in-person audience. I just want to say we have over 400 people online who are watching this program. Lots of questions about scans. People want tests to know that they're okay. And I know you've addressed this a little bit, Dr. Traina, but could you take one more shot at it?
Right, sometimes you might ask for, but couldn't I just have a scan because I just want to know? You know, just in case there's something else. What do you tell?
That's very challenging because having a scan, there is no perfect scan, there is no perfect blood test. And even having a normal scan today doesn't tell you anything about tomorrow. It tells you nothing has happened yet, but you knew that already because you woke up this morning and you're going to go to bed tonight, and that scan doesn't tell you that there isn't something microscopic somewhere. So, and we know unfortunately from trials, it hasn't helped, whatever interval of scans. I mean, years ago, scans were done on some regular basis, and whatever interval you pick, it's going to be wrong, right? There hasn't been one found. So it gives a false sense of security, and it doesn't necessarily improve outcomes by doing it. And then you balance that with, gosh, our scans have radiation associated with them, right? People are worried about doing their screening curative mammograms because of radiation, but nuclear medicine studies and CAT scans come with a whopping dose. And so if you don't need it, if it's not going to improve survival or help outcomes, then it's falsely reassuring and it might actually be harmful instead.
Yes, we'd love to hear questions from the audience right now. Yes, right.
I was just curious
So if you would repeat her question, because they may not be able to hear at home, she's not on
Right.
microphone.
So the question was, I had mentioned we don't quite understand why there's an increased prevalence of triple-negative breast cancer in young African American women, and is there research going on there? And I think a lot of the work being done is observational, also trying to create sort of tissue banks and registries where you can try to look at the biology of that cancer and see, is that different? How is it different? I'm not aware of sort of prospective intervention trials that are different, but there is work being done that's at the observational level to try to understand how that biology might differ.
Did you have a question?
Yeah. My girlfriend has triple-negative breast cancer. She's had the surgery, chemotherapy, now she's doing targeted radiation treatment, right? One of the things that her doctor and her are exploring are oral chemotherapy after radiation. Like Xeloda is one, I think. I'm just curious if you have any insight on.
Yep, so that's the clinical trial that I was mentioning that reported out at San Antonio, that following pre-op chemotherapy at the time of surgery, if there was residual disease, that there was a survival advantage to using Xeloda or capecitabine oral chemotherapy in improving what's called disease-free survival and overall survival. So now that study was conducted in Japan and Korea at doses and a schedule that's kind of challenging for us to actually deliver in practice here in the States. And there may be metabolism differences. I'm not sure we fully understand that, but I do think that's worth having a conversation with her doc about. There's data for it.
You know, I'm so glad you asked a question. I think it's really challenging for people who are living with triple negative, people who are living with people who are coping with triple negative breast cancer, and I'm wondering what you think was most helpful to you, for the people, your loved ones, your family, your children. What was the most helpful things for them to do at the time that you were being treated and after?
Let them care for you. I think, I'm totally a helicopter mom, and I would never ask for help. And I had to relinquish control and let them take care of me. My younger daughter was a sophomore in college, and she actually came home from school, took a term off, and was my chemo buddy and was my caretaker. But I had to really work hard to let people take care of me. And they needed to take care of me. They needed to to do that, to feel better about it. And I think it's hard for all of us as mothers to let our children take care of us, and even, but I had to let go of that and let them take care. And I think that made them feel like they were participating, that they were doing something. So
I think it's hard also for us to let people in.
yes.
Yeah. And ask for help if we need it. There's a question back here. Yeah.
I have a question about androgen receptors. So my mom's triple negative metastatic, and I know there's been talk about androgen receptors for triple negative. If she was like 99% positive, that's strongly positive. Is that something, if she doesn't qualify for a clinical trial, is that still something that would be recommended to avoid having like chemotherapy? I know there's a lot of chemotherapy.
And Dr. Trina, we have just a couple minutes left, so quick answer.
Right. I would encourage at this point using anti-androgens in the context of a clinical trial, and there are lots of trials going on right now in this neck of the woods even. So I would really try to prioritize studies over off-label use.
You know, we know you're information seekers, and you all have a lot of questions, and we want you to be able to continue to ask those questions. We want to tell you about a number of resources, both from Living Beyond Breast Cancer and the Triple Negative Breast Cancer Foundation. Both have websites you can go to with great information at lbbc.org and triplenegativebreastcancerfoundation.org. There is this great guide to understanding triple negative breast cancer. Both organizations worked on it together, and it's the latest up-to-date information. You can download this from either one of the organization's websites. Triple negative breast cancer is a partner with us, Living Beyond Breast Cancer, at the Fall Conference in Philadelphia this year, September 23rd to the 25th. There is a special track for women with triple negative breast cancer, so we encourage you to come. Triple Negative Breast Cancer Foundation has a 24/7 peer support online forum, which you all talked about, and there's a professional support helpline which is wonderful. And also Living Beyond Breast Cancer has specific Twitter chats, webinars, articles, and support for those dealing with triple-negative breast cancer. I think we just have a minute here, so a quick last word, very quickly. We'll just go down the line. Rick,
Live your life to the fullest, treasure every day.
Melissa?
Know that, do the best you can, and love your family, and just keep your head up and know that you're making the best decisions possible.
Kelly?
Stay away from negative people, stay positive.
All right, on behalf of the Triple Negative Breast Cancer Foundation and Living Beyond Breast Cancer, we thank you so much for joining us tonight, and we encourage you to continue looking for answers and use us as a resource. Thank you so much for being with us, and have a good night.